All right. Thank you guys for joining the American Institute of Dental Public Health, AIDPH and CareQuest Institute for Oral Health today for the data-driven economic implications of veteran oral health. I am Chelsea Chokas. I am a third-generation Navy veteran and a program specialist with the CareQuest Institute for Oral Health, and I will be your moderator today. Our presenters will be Adriana Sonic and Dr. Annalise Cothran. Adriana is a research analyst for CareQuest Institute for Oral Health. She has an MPH in epidemiology, and prior to her role at CareQuest Institute, she served as an infectious disease epidemiologist, focusing on improving data systems and promoting health equity. Dr. Annalise Cothran is the co-founder and executive director of the American Institute of Dental Public Health. Prior to 2018, Dr. Cothran worked as a biostatistician at UT Health, San Antonio School of Dentistry. In her present position at AIDPH, Dr. Cothran manages the programming, fund development, and overall organizational strategy of AIDPH. We also want to acknowledge Amber Shaver, who contributes to the analysis and visualization development of the Veteran Oral Health Dashboard. Our presenters today do not have any financial conflicts to disclose. And before we get started, there are a few housekeeping items to review. This session is being recorded and will be posted later for review by both AIDPH and CareQuest Institute. We'll spend the first 45 minutes of the presentation presenting information, followed by 15 minutes of moderated Q&A. Feel free to use the chat during the session to ask questions or to make comments. Please add your personal pronouns to your Zoom name. You can do that by hovering over your video, and there will be 3 dots that show up in the top right corner, and you can hit rename after clicking that button. We also welcome discussion via chat during the Q&A portion near the end, but please keep yourself muted. And lastly, CEUs are provided for this session by AIDPH. At the conclusion of the webinar, you'll receive a link to evaluate the session and request credits. So starting in February of last year, AIDPH and CareQuest Institute began our partnership to advance oral health equity for veterans, focusing on these 3 key areas: research, access, and advocacy, leveraging our joint capacity and expertise to tackle this issue more comprehensively. As a result of this partnership, we published a foundational white paper in December of 2021 that shows the current landscape of the veteran oral health and offers 9 strategic recommendations for improving quality of and access to oral health for veterans. Then in February of this year, CareQuest Institute supported AIDPH as they hosted their annual colloquium on transforming veteran oral health and expanded on the recommendations outlined in our first white paper. Today, we'll spend some time reviewing the visual report that we released in April of this year, and then review our veteran oral health data dashboard. During this session, we'll highlight key takeaways from our visual report. Veteran dental care stimulates the economy and improves overall health, followed by a review of our veteran oral health data dashboard, including the newest edition on medical costs. Our learning objectives today, you should be able to evaluate the current economic landscape of veteran oral health, identify opportunities to engage stakeholders in expanding access to oral health care for veterans, and visualize key data points for states and communities using the Veteran Oral Health Data Dashboard. I'll now turn it over to Annalise to review our latest visual report.
Thanks so much, Chelsea. I appreciate it. Hi, and welcome everyone. I'm very excited to be sharing with all of you today some key takeaways from the visual report that we released in April, and just highlighting our ongoing work in partnership with CareQuest Institute for Oral Health. As Chelsea mentioned, this has been such a fruitful partnership that we've had, and it really does signal a long-term investment of both organizations on improving the overall health and well-being of veterans. So I know that Anna just posted into the chat, thanks so much, Anna, a link to this visual report in case you'd like to review it alongside us today. And we kind of structured this in 3 areas: understanding how veterans access dental care, what the connections are between overall health and oral health, and then what the cost analysis and understanding of the cost of inequitable access to oral health care. And so the data that are represented in our visual report come from a few different sources, one being a survey administered last year by AIDPH and CareQuest in partnership with the VFW. And it was self-report data from veterans on oral health access and outcomes. We also analyzed NHANES data and BURFOS data, and we had a few other analyses that I'll reference later as we get to those data points. But one thing we did ask veterans, well, let me back up to just say from the beginning, as part of our foundational report, what we released in December of 2021, we keep reiterating that most veterans, 85%, do not have access to dental care through the VA. It's a very common misconception, and that veterans most of them are not eligible for dental care through the VA. Eligibility is set through congressional guidelines and through congressional vote, and that is set in the federal code. And so from those guidelines, 85% of veterans are not eligible for dental care through the VA. Of the 15% who are eligible, only about a third utilize that benefit. And so that's a place of exploration for us. And one of the questions that we had surveyed veterans about is, do you just understand the coverage available to you? And from that survey that was released last year, our key takeaway was that many veterans really don't understand the dental benefits available to them. It seems to be really clear about whether or not they qualify for medical care through the VA, and that 85% said that they did understand and that they did qualify. But if we asked them, do you qualify for dental care through the VA? Almost half of them said they just really didn't know. So we understand that we're working within a system that can be confusing and difficult to understand what your benefits and access actually look like, which could be compounding the accessibility issue of that 15% who do have benefits and don't utilize them. Another area of exploration that we're still looking into and hope to do more survey work around this year is what's preventing veterans from seeing a dentist. Based on last year's results, it's no surprise that from that 85% who do not qualify for dental care through the VA and do not have benefits coverage through the VA, the driving factor for not seeing a dentist in the past year, even if they needed to, was that they couldn't afford it. It's a very expensive endeavor. And later in this webinar, we'll talk about the cost of dental care per the data that we've been collecting. Lastly, I think it's really important to underscore that veterans actually do value their oral health. That when we ask veterans, do you want to keep your mouth healthy? That 80% of them do value this. They understand the connection of good oral health with overall health and understand that the lack of access to care is impacting them and that they want to do something about it. And so, as I mentioned earlier, thinking through the connection between dental and overall health, again, this connection veterans understand and also understand the impact that lack of oral health care has on their overall health. Per the data that we analyzed, which again includes BURFOS and NHANES data, we know that veterans are experiencing a disproportionate prevalence of chronic disease conditions that are likely related to their military service, meaning military service is exacerbating or creating more chronic disease conditions compared to non-veterans. So just kind of looking across the board, there's a higher prevalence of diabetes and heart disease in veterans compared to non-veterans. And that means that those chronic disease conditions are exacerbating poor oral health. And poor oral health, in reverse, poor oral health is creating is exacerbating those chronic disease conditions. And since veterans are struggling disproportionately with accessing oral health care, we know that this disease cycle and the poor negative outcomes that are a result of that are worse for veterans than they are for non-veterans. I also think it's important to point out that, as I mentioned earlier, veterans really understand the value of good oral health, and in reverse, understand what it means to not have good oral health. So when we survey veterans and ask them to rate their oral health compared to their mental health and their overall health, 29% of veterans, almost 30% of veterans rated their dental health as poor, compared to 15% of veterans who rated their mental health as poor, and just over 10% who rated their overall health as poor. So to me, it really shows that veterans understand this connection, really want to do something about their oral health care, but often can't because of inadequate access to care and the inability to pay. We also know that when chronic disease conditions like heart disease and diabetes are supported through consistent access to dental care for periodontal treatment, et cetera, that the cost savings are realized for the treatment of the underlying chronic disease condition. And so that's why we wanted to highlight how cost savings could be actualized through consistent routine access to dental care for veterans. And so what we pointed out here among chronic disease conditions were cost-saving models that were developed by Cigna Healthcare, and it's linked in this visual report for you to review on your own. So Cigna developed these cost-saving models and then projected them at different utilization rates for veterans, or we projected them for veterans. Then we looked at the associated costs from self-reported ED visits from our survey data. We realized when we surveyed veterans that about 6% of them had indicated, and this was a sample of over 2,000, that 6% of veterans indicated that they had visited an emergency department in the past year for mouth pain or a dental problem that was non-traumatic. And we recognize that that's a higher prevalence compared typically to non-veterans. And I can say now, having done more research, that that estimate is fairly conservative. So when we estimated the cost of those ED visits based on previously validated data, we kind of recognized that an opportunity to save that cost of visiting an ED for a dental pain issue or a mouth condition that could be treated in a consistent setting through routine dental care was totaling about $1.7 billion. Adding that to the utilization rate, so if veterans were given consistent access to a dentist and was able to receive periodontal care for conditions, for veterans who have conditions like heart disease and diabetes, knowing that treating those conditions would result in a recognized cost savings, that at a 50% utilization rate annually, we could save roughly $3.5 billion for effective diabetes management and $2.1 billion for heart disease management. Taken together, combining effective diabetes management, effective heart disease management, and avoided ED visits, together, we could save about $7.3 billion annually. And that's about 4.5 times the 2022 budget of the VA specifically allocated for dental services. So we know that the cost savings are actualized in a way that could potentially save the VA money through an expanded dental benefit. The last piece of this report focused on what do the American people sort of already believe about dental care. And ironically, through our market research, we found that most Americans believe that veterans are already receiving dental care as part of customary and essential services. And essentially more than 70% of Americans do not believe that veterans should be paying out of cost for dental, medical, or vision care. And we even asked Americans if they would feel if they would pay a small increase in their taxes if it meant that veterans could receive free dental care and medical care and vision care. And more than half of people sampled, which were, I think, over 3,000, said that they would pay a small increase in taxes if it meant that veterans could receive the most effective dental, vision, and medical care. So there is broad support for ensuring that veterans can receive access to these services and do so at a cost that is, not insurmountable to them. Lastly, in this visual report, we provided quotes from veterans that we've either encountered or have reached out to us in the course of this work over the past year plus. And I chose to end this portion of the webinar today with this quote that came from a service member who had reached out to Chelsea and I through this dissemination of this survey. And this was someone that I worked with personally one-on-one for several months, trying to find him the care that he needs. He had not been to a dentist in over 5 years. He just didn't have the money. He didn't have insurance coverage. And so at one point, I recommended that he looked into the VA dental insurance program, which provides premiums at a discount to veterans. And so he wound up enrolling in that program. And because of the limitations associated with it, he simply still couldn't afford the out-of-pocket cost, which was more than $1,000 at this point, to correct his needs. What's compounding this is that this veteran is a single father, and he has expressed multiple times that he's struggling to get to remain employed because of the state of his mouth and teeth. He feels really embarrassed by his breath and feels like it impedes his ability to interact with his employer, with other employees, and if he could get that problem solved, then he feels like he could stay employed and really be successful. But ironically, he cannot afford to pay for the dental cover for the services that he needs because he's not employed. And he's really stuck in this cyclical place of not being able to fix this problem. And I want to point out that this is not an uncommon situation. And of all the facts and figures that we're providing, I think it's helpful to remember that there are real people behind that. These are real service members who have dedicated their lives to our country, and they're struggling in these situations and in these systems that are really not serving them. And so this is why we're doing the work that we're doing. We are researchers, and we want to make sure that everybody understands the data available to make decisions about their community and their state and their programming. But at the end of the day, we're people first, and we're here to serve the veterans first and foremost. And so with that, I'd like to turn it over to Adriana to talk about our veteran oral health data dashboard.
Thank you, Dr. Cothran. I'm excited to have the opportunity today to demonstrate our veteran oral health data dashboard. I plan on showing some of the technical features, highlighting some of the key insights, and demonstrating how you can use this tool to get data insights on the groups that you are specifically interested in. Next slide, please. So there are a variety of ways that this dashboard can be used to find information to inform policy and advocacy. With this dashboard, you're able to look at trends in chronic disease conditions for your community, including cardiovascular disease and diabetes by state and veteran status. You're also able to look at oral health care utilization by state, as well as oral health outcomes. You will also be able to see what healthcare infrastructure is available for veterans in your local area and where people could possibly receive dental care. The dashboard also allows you to analyze cost burden for veterans when looking at both medical and dental expenditures compared to non-veterans. Next slide, please. So there are several different use cases to apply the knowledge from this dashboard. This data can be used for basic awareness of disparity and understanding in a quick glance. It can also be used by decision makers to inform policy planning and future community intervention. It is also a resource where veterans could potentially locate care access points in their community with the ability to see if a facility is part of the VA or is a federally qualified health center. Next slide, please. So there's several limitations to keep in mind when using the data dashboard. Most of the statistics found in this dashboard are descriptive, meaning that there is unknown statistical significance, and therefore we can't make direct statistical inferences from the data that is displayed. This dashboard pulls from several different data sources, which I will discuss in more detail with you shortly. And each of these data sources have their own limitations, so it's important to keep those in mind when using the data. Another thing to keep in mind is that survey data generally are limited in generalizability, so I would recommend caution when applying these findings to an entire population. So now I'm going to share my screen and I'm going to take you through the dashboard in more detail. Stand by 1 second. So when you access the dashboard, you'll be taken to this home screen. As you can see, there are 4 main topics that you can examine. Another thing to note is that the star button on the top right, if you click on that, you'll be taken to a document that lists and explains the main data sources that were used to create this dashboard and should provide additional context if you're looking to use these findings in any publications. So the first dashboard I'll be demonstrating is the oral health indicators dashboard. So let's dive into the data. So you'll see at the top of this dashboard that this data comes from 2018 BURFOS data. To give you a little more context about this data source, BURFOS stands for Behavioral Risk Factor Surveillance System. This data comes from a nationwide state-level telephone survey of US residents where they are asked questions regarding their health-related risk behaviors, chronic health conditions, and healthcare utilization. So this survey includes adults age 18 and older and is currently administered in all 50 states and 3 territories in the US. And it's administered on a continuous basis at the state level to provide the most up-to-date data. So people in these states are sampled using random digit dialing for both landlines and cell phones. So just keep that in mind when looking at this data. So most of us on this webinar probably know that people's overall health is related to their oral health. And the general public also believes that this is true. A recent study done at CareQuest Institute found that 96% of the general adult population knows that there is a connection between the health of their mouth and the health of the rest of their body. So this page of the dashboard highlights chronic health conditions, oral health utilization, so dental visits, and dental outcomes. And specifically, this one is looking at tooth loss, specifically the loss of all teeth. So the first chronic health condition that is displayed on this dashboard is heart disease. So when you first click into it, that's what's being displayed, is cardiovascular disease. So BURFOS data shows that veterans in every single state were more likely to suffer from cardiovascular disease than non-veterans. The shading on the map indicates how much higher the risk of heart disease for veterans was in that state. So the number displayed on the states are odds ratios of veterans' risk compared to non-veterans. So the further away the odds ratio are from 1, the more likely it is the relationship between the exposure, which in this case is being a veteran, and the disease, which in this case is heart disease, is causal. So for instance, when you hover above the states, you will see the state name and then how much more likely a veteran is to have heart disease. So the most striking example for heart disease was Utah, where we see that a veteran is 348% more likely than a non-veteran to get heart disease. Several other states also showed very high disparities, including Minnesota, where it was a veteran was 262% more likely to have heart disease, and Massachusetts, where they were 268% more likely. So clicking on the next tab, you'll see odds ratios of veterans having diabetes compared to non-veterans. So as was the case with heart disease, you'll see that the odds of a veteran having diabetes is higher in every single state compared to a non-veteran. Some notable findings from this dashboard I'll highlight is Wyoming. So in Wyoming, a veteran is 96% more likely to have diabetes than a non-veteran. Another notable state was Wisconsin. where a veteran is 105% more likely to have diabetes than a non-veteran. So moving along, the next tab looks at dental visits. So this map highlights the odds of a person having gone more than 5 years since their last dental visit. So you'll see that results start to diverge more at the state level than the previous boards. So in states with the odds ratio being over 1, such as Oregon, veterans are more likely than non-veterans to have not seen a dentist in the 5 years. So you can see a veteran is 76% more likely than a non-veteran to have gone more than 5 years in Oregon. However, in other states, like South Carolina, veterans were less likely than those who had never served to have gone more than 5 years. So you'll see that a veteran is 17% less likely in South Carolina to have gone more than 5 years without a dental visit. So differences really start to be seen between states on dental utilization. So despite these diverging utilization rates by states, it's clear looking at this fourth board that veterans suffer across the board from worse oral health outcomes. So this board displays the odds of veterans having lost all of their teeth compared to non-veterans. As you will see, in all states, the odds are above 1, meaning that veterans uniformly have higher risk of losing all their teeth compared to non-veterans across the US. So once again, just to show a few kind of striking examples, a veteran in Utah is 196% more likely than a non-veteran to report having lost all their teeth. Similarly, in Massachusetts, a veteran is 181% more likely than a non-veteran to have lost all their teeth. So while these are, this is the only oral health outcome that's displayed on this dashboard, it's certainly not the only disparity that exists among veterans and their oral health outcomes. So just something to keep in mind. A study recently conducted at CareQuest Institute found that roughly 2 out of 5 veterans described their overall oral health as fair or poor. And that can actually be extrapolated to 8 million veterans in the US with deficient oral health. So it's a very large problem. So to see other topic areas, you can click on the home button. So now let's look at the Community and Clinic Insights tab. So this dashboard highlights data from several sources. The top visualization looks at data that was collected by AIDPH and CareQuest Institute using 2 consumer surveys that were done in 2021. So these surveys collected the opinions of over 2,000 veterans. So as you can see on the top visualization, nearly a third of veterans surveyed reported they hadn't been to a dentist within the past years. So about half of those respondents hadn't been in over 5 years. So very significant issues. So Annalise already mentioned that there were a lot of different reasons mentioned why veterans had not been to the dentist, but lack of insurance coverage and inconvenient clinics was among the most answered. So looking at the bottom map, on the bottom half of this dashboard, you'll see orange dots, which represent VHA clinics, and blue dots representing federally qualified health centers. So this was taken from UDS data, which is collected by HRSA, and it should be noted that it is a very limited data set when it comes to actual dental care. However, it shows possible physical access points to care. So all of the VHA clinics are displayed on this map, regardless of whether we know they offer dental services or not. However, these could in the future serve as physical structures to house dental services. So looking at the drop-down menu on the right, you'll see that you can select individual states. You'll notice that when you select a state, the map changes as well as the bar graphs on top. So this displays state-specific data for all measures. So let's pick a state. So let's look at Texas. So looking at Texas, you'll see that everything changed at once. So all of these are displayed specifically for the state that you choose. And you can zoom in on this map with a little plus sign. Just to note, if you want to change, like for instance, I don't want to look at Texas anymore, I want to look at Tennessee. Just note that if you click this little X near the pin, then that will bring you to the new state that you select. And then you could clear all the filters by just clicking all again. So looking towards the middle of this dashboard, you can click the button that says click for out-of-pocket spending by state, which will bring you to a histogram by state of out-of-pocket spending. These responses were pulled from consumer surveys, and when you hover over the bars, you'll be able to examine the categories you're looking at. For example, in Alabama, 64% of veterans reported spending less than $500, whereas in Arizona, only 39% reported spending less than $39. If you wanted to zoom specifically in on Arizona so that you could kind of investigate that further, you just unselect all and then select Arizona, and it'll show you a bar graph specifically for the state that you're looking for. So you can see that 39% had less than 500, 34%, 500 to 1,000, 22, 1,000 to 2,000, and 5% 3,000 or over. And you could add a few states, as few or as many as you would like. Okay, so back to the home page. So next, moving on to medical costs. So the majority of data from the next medical and dental cost dashboards come from MEPS data. So MEPS stands for Medical Expenditure Panel Survey. And these data specifically come from the household component of that survey. So MEPS collects information from a sample of families and individuals across the US through interview and surveys. Demographics, health conditions, use of medical services, charges, source of payment, insurance, et cetera, are assessed for all of those households. And the data is collected by the Agency of Healthcare Research and Quality and the National Center for Health Statistics. So one note about these cost dashboards that I'm displaying right now is that all estimates are weighted using the survey weights, and people surveyed who are of unknown veteran status are included in the totals. However, they aren't displayed. So if you notice that the totals don't quite add up to 100%, it's because of those unknown veteran status that are making up the rest of the population. So the analysis displayed on the top on the medical cost dashboard, you'll see that it includes 28,000 records. These results are weighted and can be extrapolated to a grand total of 327 million records, including over 11 million veterans. So when we're looking at this page, medical expenditures are the sum of all direct payments for care, and that includes both out-of-pocket payments by the families and payments by private or public insurance or any other payments. And as shown in this dashboard, the overall average in medical expenditures, so this bar shows the average, was $8,740 per person. As you will see in this chart, the average per person expenditure for veterans was significantly higher at $11,414. So medical self-payment amount, so this chart right here, it only includes out-of-pocket costs for care by the individual or a household. So looking at medical self-payment amount, you'll see that veterans were also higher than the overall average of $955, where they reported paying $1,091. So looking to the right, these questions show who reported that they could not afford medical care. For instance, 4% of veterans reported that they could not afford medical care. And then this question is, did they report delaying medical care due to costs? And you'll see that for veterans, it was 6%. So one of the best features of this dashboard is the ability to tailor what you're looking at by demographic. So you can choose different age groups, whether to look at males or females and what region of the US they live in. you can choose to limit to one of those specific groups or a combination of all three. So to demonstrate, if you wanted to look at medical costs of men age 66 or older in the Midwest, you just have to customize this. So if you select all, select 66 or older. We just want males, and we only want the Midwest. So you'll notice that all of these change. It all is displaying that specific demographic that you're looking for. And you could really tailor to a lot of different groups that way. So going back to look at dental costs. So the same functionality exists for dental costs as well. As you can see overall, the veterans' dental care on average is costlier than non-veterans. So looking at dental expenditures, you can see that the average overall is $438 a year, and for veterans, it's $508. So that's significantly more. The difference in self-pay amount is even more pronounced in dental expenditures compared to medical for veterans versus non-veterans. You can see that veterans pay on average $276 a year, and that's compared to the average of $222. You can see when looking at those who couldn't afford care that a higher percentage of veterans compared to non-veterans reported costs as being prohibitive. So veterans were also more likely to report that they delayed dental care due to cost, with about 16% saying that they delayed care due to cost. So similar to medical costs, you can customize the data. For instance, if you wanted to look at 36 to 55-year-old females in the South, you could do that. You could select more than one at once. So 36 to 55, you only want females. And then you could also combine regions. So if you wanted the South and West, you could do that. And we do have definitions available of like the regions and things like that. So if there's ever any questions, please feel free to reach out to us. So on the top right-hand side of this dashboard is a button that takes you to more comparisons of out-of-pocket costs for veterans. So if you click on this button, you will be taken to a page that shows veterans versus non-veterans who regularly visit the dentist. So there we go. So this shows people that reported that they had been to the dentist in the past 2 years, their out-of-pocket costs for veterans versus non-veterans. So if you click over here, you can see, any kind of different comparisons you want. So for instance, if you wanted to look at rural non-veterans versus rural veterans, you just select those groups, and that you'll see that rural veterans were far less likely to pay less than $500 a year than rural non-veterans. If you only wanted to compare veterans, you could look at rural, suburban, and urban veterans to see what groups paid higher out-of-pocket costs. So thank you very much for taking this time to join us in this demonstration today. I really look forward to hearing your feedback about this dashboard. We want to make it a useful tool for all of you and look forward to hearing any unmet needs or suggestions. And with that, I'll pass it back to Chelsea.
Thank you, Annalise and Adriana. So we do want to hear from you. Obviously, we want to know what additional data does this dashboard need and how can we improve the user experience? You can share your initial thoughts within the chat or provide feedback via email to research@AIDPH.org, and we'll enter that email into the chat also. All right, and now we'll welcome any questions through the chat or the Q&A function. So we did have a few questions come in during the presentation. Brett Ryan asks, do you think there could be a link between MTF, DTF density and access, more specifically just the geographic distribution or concentration of military bases?
Yeah, I'm happy to perhaps give some feedback on that. And thanks so much for the question, Brett. I think because of the number of veterans who are not accessing care through the VA or TRICARE system, if you're a retiree and qualify for that, it would be difficult to say that those access points are accounting for a difference in those indicators. So I guess there's a caveat there. One is I can't say for certain. I don't think any of us can, right? It's still an area of exploration because what we're presenting now, I think, is the most amount of data in a central location on veteran dental care that exists, recognizing that AIDPH and CareQuest have a large cadre of data that we're still trying to process and get out to people because we don't have all of the answers. I think that's why I'm excited to actually have some time here today to hope to get feedback from this audience, because the dashboard is really meant to democratize the data that we've been collecting. We need community insights, we need community supporters, and we really need folks to ask important questions like this so that we can direct resources and questions and next steps toward answering those questions. So I guess my first thought specifically on that was, because of the number of veterans who are not accessing care in a centralized place like TRICARE or VA, we've been trying to analyze veteran outcomes based on this very fragmented system that all Americans experience. It's not just veterans. So it's hard to sort of tie connections there. Also, on that note, I will say that on the Community Insights dashboard that Adriana just shared, one of the limitations there is that the FQHCs that are displayed and the VA clinics that are displayed are not specific to those who have a dental clinic. And we've heard feedback from veterans that sometimes they go to a clinic that may be on the VA website and couldn't access their care there or didn't understand the process of how to do that ahead of time, et cetera. And so some of those connections that maybe we could look at through geographic distribution are limited because it's not always clear whether or not that clinic location has a dental operatory. However, I think what it does highlight is the opportunity to use those locations because the infrastructure is already there as access points for veterans, knowing that FQHCs have an integrated care model and are really positioned to do fabulous coordinated care holistically for veterans and all Americans. And then also the VA is the largest integrated healthcare system in the US across the board. And so some of that is, I hope, a mechanism of indicating where the opportunities are so that we could look at geographic distribution of outcomes and associations more closely. Chelsea, did you want to moderate the next question?
Yeah, sorry, I was looking at the questions. So this one is more of an interesting point out, which I noticed as we're going through the dashboard also. What are the contributing factors of why D2I mass have such high edentulous rate compared to other states? I don't think we can specifically answer that, but it's something that we should definitely dive into now, seeing that displayed and presented to you guys. And then there was another question from, let's see. Another question from Brett Ryan. Regardless of status, i.e. separated or retired, where do all the vets end up? My line of thinking is that you may have familiar dentists in areas with a higher density of active duty military, more dentists who are on active duty. So I think that's a follow-up to his original question.
Yeah, I think that's a fair point, Brett. And one thing that we've been attempting to create is a network of people who are, or organizations that are working with veterans. I think we mentioned this earlier, we may not have, but because veterans are experiencing such disparity in accessing care, there are many organizations, charitable organizations, who are sort of standing in that gap. Like Dental Lifeline Network is one of them. Everyone for Veterans is one of them. There are a lot of charitable organizations that are looking to sort of create access points for dental care and are doing a really good job in the system that really isn't meeting veterans' needs currently. So among that group of advocates is, like you just mentioned, people who are military friendly, who can provide pro bono care for veterans, who are really kind of putting themselves out there saying, here I am, and I really want to serve this community. And I think that's maybe an area of opportunity that we need to look into, and that is there a place where all of those people can come together in a more central, coordinated manner and be able to have veterans go to that central location. Maybe it's this dashboard one day where you can say, okay, I see all of these access points in my state. Here's a dentist in my local community who's willing to accept my case pro bono, or a dentist who understands the needs of veterans. Maybe they're a veteran themselves and they really understand trauma impacted care and all of these other issues related to the clinical care of veterans. So I think that's a really helpful next step. I want to note that there are organizations doing that. And they're doing a really fantastic job. And two, there probably needs to be a more coordinated system while we wait for coverage to expand for veterans, that all of those organizations can work more in concert together.
Another question from an anonymous attendee. Was there any analysis to assess where veterans landed in terms of federal poverty level?
That's an interesting question. And Adriana, I'll pass it to you when I get this first thought, which is, while it's not released on the dashboard, we did an analysis internally looking at income and just kind of seeing descriptively if there were differences. And I think we sort of hypothesized that those in the lowest income category, so those who are at $30,000 or below, would have the hardest time meeting their needs in terms of getting dental care, and that they would have poorer oral health outcomes. And interestingly, what we saw is in the $30,000 to $60,000 income category actually had the highest negative oral health outcomes. And that's likely because those people in those categories don't qualify for Medicaid or other subsidized bear with me, y'all, subsidized programs that would account for a very, very low income. So interestingly, in our data, we noticed that those who were in that low FPL category actually didn't have the most issues paying for dental care. It was those who didn't qualify for the programs that would help kind of serve as that safety net, so that they were spending more out of pocket, more from routine income, and didn't have additional resources to help. So Adriana, I don't know if there are other interesting findings that you could share kind of anecdotally or through your observations of our data collection.
I think it's a really interesting point and one that we should definitely look into further. I don't have any additions to what you said, though.
Are there any additional questions? Please enter them in the Q&A function or through the chat, and we'll be happy to answer them.
I'm also particularly interested in knowing if we should be prioritizing certain data points for the community to use. Again, our goal through this initiative is to democratize data as much as possible. And so that means that we put out the data that is most used by the community, has the highest need, and that decision makers and advocates like all of you can push that out for your needs. So if you have thoughts or feedback on that, I know AIDPH and CareQuest really want to make sure that we're giving you the tools that you need as the everyday people doing this work to be as successful as possible as you're making these decisions.
I also saw that Brett added another question. Have you made any outreach with TAPs for those separating? And that's something that we've actually discussed. So I separated from the military almost 7 years ago, and the BADIT program was released about 2 years after that. So obviously during my transition out, I did not receive any information about dental benefits, but it is something that we want to know. Are veterans being, or future veterans being told about the BADIT program or what is available to them? Because I know they are communicated about DAV and through the VA, but dental is something that we're not quite sure of, but it's something that we want to definitely find out. And then Pamela Smith just put a question in the chat. Veterans will still need to go through the VA dental clinic to go to a FQHC or community provider. The veteran cannot just go to an FQHC and community provider and receive their VA dental benefit. There is a process to receive those benefits, much like the predetermination with insurance. The VA dentist provides the codes for what procedures the FQHC community provider can perform and receive reimbursement on a determined reimbursement amount. Are you aware of this process?
Thanks for the comment, Pamela. I think you're right. It's really complicated, and that sometimes FQHCs can receive reimbursement from veterans who are covered through the VA. And then for those who are not covered through VA benefits, they would sort of come in as any other person who could pay out of pocket on a sliding scale fee. Maybe they don't have any insurance coverage whatsoever. Maybe they have VA DIP coverage, and it really does get complicated. So I appreciate you highlighting the complexity of this and really showcasing why it's important for us to have more centralized access points and coverage for veterans so that they have opportunities to go to the providers that they need to go to that meet their needs geographically and care-wise too, in terms of care delivery.
I also saw a comment asking if anybody can connect with us after this webinar. We will share our emails in an email that will go out after the webinar is finished. So feel free to reach out to Annalise or myself.
And thank you for highlighting the success of Oregon. I think we've known about it. We're so excited. And I guess I would encourage everyone too to go look at what Oregon did. They were able to successfully expand Medicaid coverage to include veterans, which is a huge win. And that's something that all states could certainly look to as a model for a policy or advocacy opportunity, and look at what Oregon did and talk to the folks there as local advocates who were able to successfully improve a policy for their state and for veterans.
And just one last call for any final questions. All right. Not seeing any questions coming through the chat. I just want to thank you all for joining us, and we hope you enjoy the rest of your day. And there will be an email coming out shortly with our contact information.